links to exciting Issachos content, offerings, and more. Speaking of offerings, we have a special offer for attendees of this webinar. Apply for a new Issachos membership now and receive $29 off to celebrate 29 years of Issachos. To take advantage of this offer, use promo code Issachos29 at checkout. And with that, let's turn the webinar over to the chairs.
Hi everyone, welcome to the Issachos webinar on what you need to know about ACL reconstruction in pediatric patients. My name is Dr. Adnan Saithna and I'm the chair of the Young Professionals Task Force, and it's also my pleasure to be the chair of the webinar today. I'd like to introduce my colleague and good friend, Dr. Eduardo Monaco, who's Professor of Orthopedic Surgery in Rome, who's going to introduce the topic.
Thank you, Adnan. Welcome, everybody. We chose this topic because I think this is a very, very hot topic today. There are a lot of the number of patients with pediatric patients with ACL injuries is increasing a lot, and every surgery is complicated by different aspects, and we have to manage different problem when we have a pediatric patient, from the skeletal maturity of the patient to the drilling technique for the ACL reconstruction, associated procedures in order to reduce the failure rate, which is very high for this kind of patients. And for this reason, we invited some experts to speak about all these particular aspects of ACL reconstruction in pediatric patients. So welcome everybody and join the meeting. Thank you, Adnan.
Thanks, Eduardo. So we're going to get right into it. And our first presenter is going to be Dr. Matthew Fury, and he's going to be talking about evaluation of patient maturity. So Dr. Fury is a sports medicine surgery out of Baton Rouge Orthopedic Clinic. His clinical faculty at Louisiana State University. He did his residency training at the Harvard program and a fellowship at HSS. Dr. Fury, please go ahead.
Great. Good morning, good evening from wherever you're joining us from. Thank you for the opportunity here. My name is Matthew Fury. I'm a sports medicine surgeon at the Baton Rouge Orthopedic Clinic, also clinical faculty at Louisiana State University. And I've been tasked with talking about how we evaluate patient maturity in the setting of pediatric ACL reconstruction. And so, as Eduardo had mentioned, the incidence of pediatric ACL injuries is rising worldwide. This graph on the left shows a study that was performed in Finland, showing this year-to-year increase in the incidence of ACL injury. And also on the right side, you can see this graphic from Australia seeing a similar increase. And what we know now with our recent literature, historically we've told these patients, wait for skeletal maturity, wait for your growth plates to close, and then we can perform adult type reconstructions. But our recent literature has demonstrated that operative treatment is better, demonstrates better return to sport rates when compared to non-operative treatment, and that earlier reconstruction is associated with decreased rates of secondary meniscal cartilage injuries when compared to delayed treatments. And so because of this, because of increasing incidence and increasing emphasis on earlier operative treatment, we've now seen this trend, which is a study from 2014 published in AJSM, which demonstrated an increase year to year over a 20-year period of pediatric and adolescent patients undergoing ACL reconstruction. This was in New York State in the United States. And important concepts for pediatric ACL, treating pediatric ACLs, that kids are just simply not little adults. If you look here in this right picture, this is 6'7" American baseball superstar Aaron Judge with two young fans, and these three patients are just simply not the same. The picture on the left shows the pediatric skeleton in the presence of physes complicates our decision making, complicates our surgical techniques, and takes a lot of thought in how we work through the effective and appropriate treatment for these patients. Because what we're trying to avoid is this situation like this, where you perform a surgery or reconstruction which ends up producing a physeal bar formation and a clinically significant growth disturbance. So really the important goal of treating pediatric ACL injuries is how do we stabilize the young knee while respecting the growth potential? And so we performed a systematic review a couple of years ago which was the largest systematic review in the literature. We're looking at 100 articles. We wanted to assess the rates of postoperative growth disturbance, whether that's leg length discrepancy or angular deformity. And also we wanted to look at how we've historically assessed growth remaining and postoperative growth disturbances in the literature. And what we found was that the incidence of leg length discrepancy and angular deformity was quite low. It was 2.1%, 1.3%, with the best data that we had available. However, when looking through the literature, we as a society, as surgeons, have been quite poor at assessing growth remaining, how we've reported it, how we've discussed it amongst each other. And so we have concerns regarding our vigilance and our awareness for this concept. And so I'd like to go through some of the things that I consider and things that I recommend considering when you're treating pediatric ACL injured patients. So chronological age, which was cited in essentially every study in our systematic review, I would offer has really little use in your treatment algorithm, because as you can see here in these pictures, this is on the right side, these are two players in the Little League World Series in the United States, both 12 years old, and you can see not all 12-year-olds are simply the same. Historically, we've also used secondary sexual characteristics, whether it's Tanner staging or onset of menses, and I would also offer that has limited role in the current algorithm today, because these methods they're inaccurate, they're intrusive to this younger vulnerable population, and they can be affected by other factors, training and nutritional status. And so what we've learned from a lot of our colleagues who have done growth deformity, growth modulation in the treatment of deformities is that skeletal age is really critical in assessing how much growth the patient has remaining. And so this study, which was published in JBJS, demonstrated that 26% of patients had a skeletal age that differed by greater than 1 year when compared to their chronological age. So when you used skeletal age instead of chronological age in some of the growth prediction models, your error was much reduced. And so there are now many methods to assess skeletal age, and these have been used historically, the GP method, Tanner, Whitehouse, Sanders. There are now techniques that use various different anatomical locations, whether it's the olecranon, the clavicle, the thumb. And these methods are quite cumbersome. There's a lot to look at. We've developed now shorthand bone age methods, which this is pictured here on the right, which really isolates down to the most influential structure that you can assess to try to determine a patient's given skeletal age, which simplified a lot of these other atlases, which we've had to use historically. And now, recent studies have demonstrated that artificial intelligence and machine learning that's been trained on large data sets may outperform some of our human assessments of skeletal age when using the GP and other skeletal age methods. Now, the historical ways of assessing skeletal age have involved getting hand radiographs, elbow radiographs, other additional imaging, when at least now in the modern day, most of our ACL patients are coming here with an MRI. So there's great value in potentially being able to assess skeletal age and growth remaining by using the MRI. And so this has recently been published with an MRI atlas of the knee in order to use this to determine skeletal age. And it's been subsequently condensed into a shorthand form, which was done in this study here. And you can see from the chart on the left side that the shorthand knee MRI atlas has demonstrated equivalent or improved inter-observer and intra-observer reliability when compared to some of our hand methods. So how do we use this information? The key is really understanding how much growth is remaining and how that relates to a patient and their risk of growth disturbance. So what we know now is that skeletal maturity tends to occur in boys around 16, girls around 14, and each year the distal femur contributes about 9 to 10 millimeters per year of longitudinal growth. Proximal tibia contributes about 6 millimeters a year, and that majority of our patients that become symptomatic occur somewhere between 1 to 2 centimeters of leg length discrepancy. So when you put all this together, to summarize, patients with greater than 2 years of longitudinal growth remaining are relatively high risk for a growth disturbance. Between 1 to 2 years remaining, I would consider in the medium or moderate risk cohort, and then less than 1 year of growth remaining, I'd consider it to be in the low risk the low risk for growth disturbance cohort. And then we take this risk stratification, and then we meet that to our surgical techniques. And I'm not going to dive into the various different surgical techniques available because Nick Pascos is going to touch on that just shortly. But there are surgical techniques that are physeal sparing, that either are all extra-articular or all epiphyseal. We have techniques that are physeal respecting, which means they may be transphyseal with soft tissue grafts, different ways of technically drilling your tunnels. And then there are adult type reconstructions, whether it's using bone blocks, crossing physes with our implants and things. And so in general, we consider these physeal sparing techniques to be the lower risk cohort, physeal respecting, and then medium risk, and then the adult types and the higher risk. However, it's important to note in the study that we did a couple years ago that we did see some growth disturbances reported in all these various techniques. So you're not totally out of the woods or safe just by doing a physeal sparing reconstruction. And so what about other preoperative workup? And 90% of the population has some element of a baseline leg length discrepancy. It's often less than 1 centimeter. In this review by Dr. Saberwalt demonstrated, or they've reviewed all the various ways of assessing leg length discrepancy. And what they determined was that radiographic measurements were better outperformed clinical measurements. And their recommendation at the end of it all was a standing full length AP radiograph, both lower extremities, with using a lift to level the pelvis, magnification markers to make sure that your measurements are appropriate, and measuring mechanical axis because they were less sensitive to things like foot position, knee position, and rotation, were the most effective ways of assessing for leg length discrepancies. Now, important note, foot and knee position is critical in these patients because some of these patients come in after a knee injury and they're unable or unwilling to fully extend their knee, or they hold their knee externally rotated, and that can affect some of your preoperative measurements. So you got to be very particular with your positioning. And there have been some recent studies which have talked about assessing for angular deformity and maybe correcting coronal alignment simultaneously with ACL reconstruction. At this point, it's really limited to some case series that have shown it to be safe, effective, but we really don't have enough data to set guidelines here on the recommendations, at least in my opinion. So my current algorithm is seen here. So the patients that are in our highest risk, females less than 12, males less than 14, I choose physeal sparing techniques. The highest or the lowest risk patients, I proceed with adult type reconstructions, whether that's bone blocked procedures. And then the middle ground is often a soft tissue graft plus or minus some extra articular procedures, at least in my hand. So I just wanted to take us through a case on how I use this data to work through a patient's workup. So this is a 12-year-old patient, had a left knee injury while playing basketball, otherwise healthy, presented with diminished range of motion, had an effusion, joint line tenderness, and positive McMurray, suspicious for a medial meniscus injury, but also had a tubulockman, otherwise was stable on exam. And you can see by the radiographs, open physes, and the MRI demonstrated a bucket handle, medial meniscus tear, and an ACL tear. And so I went to the MRI and looked with our shorthand axis to look at certain factors. So starting here at this top line, looking at the presence of this cleft or crack between the tibial epiphysis and the tibial tubercle, well, that's no longer there in this patient. So they've now progressed out of that 10.5 year skeletal age. But if you look here on the right side of the image, they still have the presence of what they call the Oreo sign. So this differential gradient between the subchondral plate and the articular cartilage. So my assessment was that this patient, their skeletal age was 11.5 years of age. So 14 years old minus 11.5, she had 2.5 years remaining, which put her in the high risk cohort, in my opinion. We got our preoperative long leg alignment film. She had a neutral axis. So we performed an extra articular IT band ACL reconstruction and also fixed her meniscus. Great, thanks for the opportunity and enjoying the rest of the webinar.
Matt, thank you for that excellent and very clear presentation. We're going to take all questions after all the panelists have completed their presentation. So please use the Q&A button at the bottom of the screen to share any questions that you want the faculty to address at the end. Our next presentation is going to be on surgical techniques, and this is going to be from Dr. Pashos. Nick's an experienced orthopedic surgeon, and he serves as co-chief of the Division of Pediatrics at Mass General, and he's also Director for Youth Sports at Mass General Brigham. Nick, please go ahead.
Thank you so much, Enan and Eduardo, for the invitation. It's a great pleasure to be here. And thank you, Matt, for the great introduction and the great assessment that you have. These are my disclosures. None of them are relevant to this presentation. And one point that I want to make is that don't let the technicality or the hard things that you may hear in the next few minutes as I describe the techniques make you believe that it's okay to either treat these patients conservatively or to wait their care, because as Matt pointed, cartilage and meniscus injury are happening, and it is a very, very serious complication that can happen after an ACL deficient knee. Are there pediatric Coopers? This is a 9-year-old female gymnastics game, and everybody was saying that the ACL was okay, was scarred on the PCL. This is 6 months later with meniscus injury and a completely torn ACL, so it's not going to go well. What are the things that you need to be considering? Obviously, you need to be aware that the growth will continue. These patients have other considerations as well. They have a high activity level and probably relatively poor compliance. So you need to incorporate this in your whole management plan. The knee is much, much smaller, so these create some challenges on their own. And another thing is that we have to use an autograft. Allograft is not an option because, as we see from the MOON data, and also some prospective studies, we have 3 times higher failure rate with an allograft. So we need to use an autograft for these patients. These are the techniques schematically. We have the physical sparing, and here you can see that we use the IT band and go around. We loop it inside the knee. We'll see more detail. We have the all epiphyseal that we create tunnels, but we need to create the tunnels, and we need to have the fixation points within the physis, because in that way, the growth of the patient won't stretch the ACL as the patient grows. And then we have the partial transphyseal technique for these patients that they have less than a year of growth, but still you have to protect the femoral side. So you need to do an epiphyseal type of fixation on the femoral side. And then we have less than a year of growth, and you can go and perform your complete transphyseal, kind of an adult reconstruction. But there are always some modifications that you can make for these. This is my algorithm. I couldn't agree more with what Matt was saying about skeletal age. I think you can incorporate all the different things, and everything is, everyone is a little bit different, but the algorithm would be as well for skeletal age, girls and less than 11, boys less than 12, definitely a physical sparing technique. When we have that gray zone between 12 to 14 and boys for like 12 to 15, sometimes we can do a partial, like physical respecting technique. And then when you are very close to skeletal maturity with an assessment of the skeletal age, then you can do transphyseal ACL reconstruction. Sometimes for these techniques, you need specific equipments for the ITB transfer, for some of the harvests, of the hamstring harvest. You need specific equipment. These are equipment that I typically use for the techniques that I use. And also you may need to have the tunnel, applied tunnel socket, to be able to do an assessment of the graft to create a tunnel. Now, these are like the technique of the IT band technique. And this is the areas that we mark the incisions. So we need to mark an incision that will allow us to take a portion of the IT band. I will start my video. Hopefully it won't be any sound. Sorry about that. So what you need to do is essentially to make an incision that will allow you to get about 1 centimeter from the posterior part of the IT band, and then create a kind of a 2 centimeter band because it's very, very thin, as you can see. I use the scope to go further up. And one trick that you need to do is to release the ID band both from the superior part, from the adhesions that you have from the skin and subcutaneous tissue, but also to go here and essentially release the adhesions from the lateral quad. That will allow you to essentially slide your harvester to be able to obtain a graft that's adequate length, so you can have enough space to loop it around in the knee, as you see it here. So you keep the IT band attached on the Gertis tubercle, and then you loop it over the top, as we see here. And here you can see that I use the closed harvester because that allows me to measure the length of the area. It's a little bit tricky to make sure that you size it and you put it so it can go all around the harvester. And then as you've seen here, I go in, I measure the length, I aim for 15 centimeters, and then I close the harvester and I take it. And then you need to tubularize the graft. So the 2 centimeter very flat graft, you need to make it tubular. And then you go to the over the top position, and then you bring the graft from around the side on the other portal. And then here we are above the intrameniscal ligament. But then the next step is to create a groove, as you can see here, and I have my glove. So create a kind of a small groove onto the bone, so it will allow a lot of bone healing in that area. And then you bring the graft and the suture from here, so it's under the intrameniscal ligament. And then you have to fixate it on the extra-articular portion on the lateral side. And I use stitches, I use periosteal stitches, and then I stitch it on the front of the tibia. And then the graft is pretty solid. Now, in some patients, I would use an all-epiphyseal technique, which essentially needs fluoroscopy. You need fluoroscopy, and you need to be well above the physis because your tunnel will be a little bit larger than the guide. And then I use the flip cutter here, like in order to create the tunnel. And then I use fluoroscopy for the front of the tibia. And again, I make a blind socket technique, put my end button, I pull all the graft in, and then I put it on the tibia side. And I aim for a 60 to 65 graft, no bigger than that, because then you don't have enough space in these spaces to go for a 20 tunnel. Typically, I go for a 15 on each side, so as to make sure that you stay within the epiphysis. And this is the technique that's coming from Italy that essentially does the exact opposite thing that we do here in the States, taking the IT band. What this technique describes is that you take and you separate the 2 hamstrings, and then you have the guides under the intrameniscal ligament and over the top. And what you do is essentially you take from the part of the inside the intrameniscal ligament and you pull it over the top. And then what you do is for the lateral incision, you create that fixation both on the femur and both on the tibia, and you can use either an anchor or a periosteal stitch for this. The advantages for the 2 techniques, if you want to compare them, is that probably the physical sparing has lower risk, regardless if you use the IT band or the hamstring of physical injury. And it's a soft tissue, extra-articular fixation, so it has a little bit of more forgiving characteristics if you make it too tight. Also has the advantage of the extra-articular part fixation that we know now with ALT and ALL augmentation, how powerful that can be. The disadvantages is with IT band, we have a lateral thigh bulging, and with the hamstring, we have the loss of the ACL protective effect. And obviously, sometimes there can be a fixed side, and it's kind of a non-anatomic technique, or that's the criticism. With the all-epiphyseal is more anatomic. We can use a nice graft that we have used in the past that doesn't stretch out. And disadvantage is that theoretically you have a higher risk for growth disturbance, and you need fluoroscopy, so it takes a little bit more time. The fixation is also very important. So be careful when you use screws, being very, very close to your physis, because it can create a physical bridge. And then there is a big discussion on which is the best graft, whether you use the all epiphyseal, whether you use a hamstring or a quadricep. I think the quadricep has proven and has been popular over the last years, and I think it's becoming more and more popular, but you need to be careful not to take a big graft. But these patients, I think size 7.5 to 8.5 is more than enough. Complications, obviously, they fail more, but they fail more on the other side, so they have the higher activity level. Growth disturbance is something that happens, and you need to monitor and you need to follow up these patients. As Matt said, is not traumatic, dramatic, but in any technique you can have growth disturbance. And arthrofibrosis is something that you see, so you need to be careful for these patients. Last thing, I'm not going to go anything, but in the era of ACL repair, I think it's an obligation to describe this technique that essentially is a technique of the tibial spine avulsion, because you see these very, very often in these kids. And essentially, this is the bone that is flipped up, and you have to clean the bone. I use 2 tunnels with loop sutures, and I pass a tape, and then I adjust that ACL down, and I make sure that that line is non-displaced. Same technique here. I think you need to confirm the ACL integrity. You need to see if there is a propagation of the tear back on the PCL. And sometimes I use a K-wire to fix it, but I think it's very, very powerful. You're going to use a screw. I don't use a screw because it needs a second surgery. It needs fluoroscopy. So make it simple. I think the current techniques allow us a lot of things. So in conclusion, they are increasing, and they are something that they will see you. You will find a patient that you will be seeing that is very, very interesting, that it's so young and have an ACL tear, and it's real and it's happened, and you have to fix it. They fail more, but the return to sports is quite high, and I don't think if you do it right that you have to be afraid. But again, you need to be careful. You need to prepare. You need to have your techniques down. You need to make sure that you have the instrument size, and you need to be very careful with your post-operative care. Thank you.
Excellent presentation, Nick. Thank you. We're going to move on to the next topic, but in the meantime, if anyone has questions for Nick, please put them in the Q&A. Same for any of the other faculty. Put the questions in the Q&A and we'll come to them at the end. Our next speaker is Dr. Mary Mulcahy. She's Professor and Chief of Sports Medicine in the Department of Orthopedic Surgery and Rehabilitation at La Loya University Medical Center in Chicago, and she also currently serves as the chair of the ISAKOS Gender and Diversity Task Force and a member of the ISAKOS Shoulder Committee. Thanks, Mary. Take it away.
Excellent. Thanks so much, Adnan and Eduardo. Thanks, Matt and Nick too, for great talks leading into this. So here we go. So these are my disclosures, none of which are directly relevant. We're going to touch a little bit on some of the additional background information related to ACL tears in pediatric patients, very briefly on treatment options, because we just heard a great talk about that. And then really I'm going to highlight results and complications. So pediatric and adolescent ACL injuries have increased significantly over the past couple of decades, and the incidence in this group is about 14 per 100,000 exposures. Looking at the age group under 15, the incidence of ACL tears has increased over 400% from the early 90s to the early 2000s. This increase in pediatric ACL injuries is due to a lot of different factors, including an increased level of sports participation and the overall intensity or level of play. And certainly these patients are starting to play sports at a younger age. They're focusing and really specializing in sports earlier on, and we have certainly improved diagnostic measures. So there's still, as we've heard a little bit about, there's still some controversy regarding the best treatment strategy for pediatric patients. Conventional ACL reconstruction, or what we do in adults, certainly puts the distal femoral and proximal tibial physes at risk. And as we've also heard, and it's really important to remember, that delayed reconstruction leads to a risk of cartilage and meniscus injury. So there are some injuries in kids that are similar to adults, but not injuries in the knee, because we have to keep in mind the physes. So the physes around the knee are among the fastest growing in the body. And when they are insulted or injured, that can lead to growth disturbances. So we have to take into account very careful consideration of the physes. We heard a great talk about during determining skeletal age. So just as the reminder, right, about the rate of growth at the distal femur and proximal tibia, the growth is significant, and we have to keep that in mind. To treatment, very briefly, non-operative versus operative. Non-operative management, really, we are moving away from this in our pediatric patient population because of the huge risk of meniscus and cartilage injury, and certainly the risk of chronic knee instability. There are physeal sparing techniques, which can be technically challenging, but of course, the advantage is that it avoids bone tunnels that cross the physis. And for some, there's still a lack of consensus, but I think we are really moving towards much earlier operative intervention. This is a relatively recent study where they looked at non-operative versus early operative versus delayed operative management. And the studies that evaluated non-op management found a high rate of secondary meniscus tears, chronic knee instability, and a low rate of return to sports. Those that evaluated early operative management found that more than 50% of patients were able to return to their pre-injury competition level. And then those evaluating delayed operative management had similar outcome scores as early operative management. So again, key takeaway point here is that delaying ACL reconstruction in this patient population for more than 3 months leads to a much higher risk of meniscal pathology, and even specifically a higher rate of irreparable meniscus tears. And bearing this in mind, with this risk of any meniscus tear, that really favors early operative intervention in our pediatric patients. We have to treat these kids based on their physiological and skeletal age. We know skeletal maturity occurs at about age 14 for girls and 16 for boys. And we, of course, want to do everything we can to minimize the chance of growth disturbance by avoiding iatrogenic injury to the physis. Keep in mind also that the origin and insertion of the ACL are in very close proximity to the distal femoral and proximal tibial physes. So we have to understand the physeal anatomy and our reconstruction options when we're planning surgery in these kids. Early ACL reconstruction definitely leads to reduced instability, significantly reduced rate, decreased risk of meniscus tears, and an increased rate of ability to return to sports. So there are a lot of advantages. Physeal sparing, we heard great talk from Nick with the details of this, so I'm certainly not going into any great detail on it, but physeal sparing, we avoid bone tunnels across the physes. This is appropriate for our kids with the most amount of growth remaining. And the McKeely technique, as Nick went through in detail, is most commonly used and involves a combined extra and intra-articular reconstruction. This is all epiphyseals recommended for our skeletally immature patients with significant growth remaining, and there are similar benefits to physeal sparing, but it does also help restore the anatomic footprint of the ACL. And in this case, of course, the tunnels or the sockets are entirely within the physis, or within the epiphysis rather. And then graft types considered in this case are hamstring and quad autograft. And then there's partial transphyseal, where you can consider this in kids who have a little bit less growth remaining. Femoral graft fixation is intraepiphyseal, and the tibial tunnel is drilled through the physis. But this avoids injury to the distal femoral physis. And for the tibial tunnel, you can make it vertical and smaller, which then in turn leads to a limited impact on the proximal tibial physis. And then transphyseal, so this is what we do, of course, in our adults. This is appropriate for kids with limited growth remaining. So males with a bone age of about 15 to 16 and females with a bone age of about 13 to 14 years. So the tunnels are drilled in a standard fashion, but there is a chance of iatrogenic growth break injury, but it can be mitigated by using smaller and more vertically positioned tunnels. And then very briefly on graft choice, we take into account a lot of factors in these kids. So graft size, overall failure rate, the risk of morbidity to the patients, and then requirements for bone tunnels. Additionally, we want to keep in mind post-op rehab and return to sport outcomes. We have several options: IT band, hamstring autograft, BTB autograft for our, essentially skeletally mature kids, quad autograft, which has become more and more popular, as we've heard, and then allograft really is not an option in these kids. Briefly on quad autograft, when looking at quad versus hamstring autograft, quad has been found to have a significantly lower graft re-rupture rate compared to hamstring autograft, but there's no statistically significant difference in the risk of re-rupture with or without a bone block in terms of the quad autograft. And then contralateral ACL injury rate is similar to that seen with hamstrings, and mean outcome scores are significantly better with quad compared to hamstring. And then there was no significant difference compared to hamstring in terms of growth disturbance. So with quad, there are very encouraging outcomes with regards to lower graft rupture rates, better functional outcomes, and comparable contralateral ACL injury rates and growth disturbance when compared to hamstring autograft. Now, results and complications. There are some significant post-op concerns that we have to keep in mind for pediatric patients. Our young active patients are those that are at highest risk for graft failure and contralateral ACL injury. There are studies that showing their 30% rate of secondary ACL injury among our adolescents who undergo ACL reconstruction. Additionally, we've seen 20% revision for graft re-injury rate and contralateral ACL injury rate in kids undergoing revision. Fortunately, about 55% of them were able to return to sport at the same level. And then there's still debate with kids, as we've seen in adults too, about timing for return to sport. Looking at outcomes and physeal sparing techniques, there's a low revision rate in our pediatric patients. There are no reported cases of, or very limited reported cases of growth disturbance. IT band overall restores better AP and rotational stability and helps restore the native constraint of the ACL. A relatively recent study by Coker showed about a 4.5% revision rate and high outcome scores in terms of IKDC and Lysholm. For all epiphyseal techniques, there are high scores in our patient-reported outcome measures with regards to knee function and return to sport. Revision rates range from about 4 to 15%, and there have been some cases of growth disturbance and leg length discrepancy, but those rates are overall fairly low. And biomechanical testing has shown that it doesn't restore knee stability to the same extent as using the IT band. For complication rates, here they found in this 2021 study, there were no symptomatic growth disturbances requiring intervention. Pretty similar rates of unilateral early physeal closure, angular deformities, a little bit higher rate of limb length discrepancies, and about 5% of patients developed a contralateral ACL reconstruction, and some required a screw removal. Additionally, they noted about 10% graft rupture, 5% risk of meniscus tear, and a small amount of tunnel widening. So they concluded that all epiphyseal reconstruction appears to be a very safe option. Short-term to medium-term complication rates are overall fairly favorable. And then growth disturbance, graft rupture, and contralateral ACL rupture are fairly similar to previous studies. For transphyseal ACL reconstruction, very limited reports of growth disturbance, especially if you're taking into account drilling smaller tunnels, making them a little bit more vertically oriented. And if this is done in our patients who are essentially skeletally mature, there's a very low risk of disturbing or disrupting the physes. MRI studies can show some damage to the physes with transphyseal drilling. And then there's some evidence that augmenting small hamstring grafts with allograft for transphyseal reconstruction can lead to increased failure rates. So again, we're really trying to avoid allograft in any regard in these young patients. This recent study found that all patient-reported outcome measures improved over the study period for transphyseal ACL reconstruction. At about 2 years, 90% of patients were participating in their pre-injury pivoting sports. At about 4 months, all of the patients had a resolution of their pivot shift, and there was no change in laxity difference between the limbs over time. Specifically related to complications, there were no surgical or post-op complications noted, and no patients ended up needing any subsequent surgery. So they concluded that patients had high patient-reported outcome measures, there was a high rate of physical performance and return to sport, and there was no evidence of growth disturbance or excessive graft laxity, and no re-injury was observed. So very encouraging. So key points, some things to take away. We know ACL tears are incredibly common in pediatric patients, and there is very convincing evidence from the literature to show that we should be operating early in these patients. So early ACL reconstruction decreases the risk of meniscus and cartilage injury. The technique that we use is based on skeletal maturity, so we should absolutely be evaluating that. And then overall, patients have excellent outcomes and a very high rate of return to sport. So thank you again. Thanks so much for your attention, and enjoy the rest of the webinar.
Thank you, Mary. Outstanding presentation. We're going to move on to our next presentation, but again, for people joining the webinar along the way, if you have any questions, please put them in the Q&A section below at the bottom of your screen, and we'll come to those after the next talk. The next speaker is Dr. Alessandro Carrozza from Italy. He's an orthopedic surgeon at the Medical Institute of the Italian Olympics Committee, and he's going to be talking about how to reduce failure rates in the pediatric population and the role of lateral extra-articular procedures. Thanks, Alessandro.
Thank you for the introduction and for the invitation. Can you see my presentation?
Yes, we can. Well, actually, we can't see your screen yet. We can see you, but not your PowerPoint.
Okay. Can you see my PowerPoint?
Not yet. I don't know if you see the share screen button at the bottom of your screen. You can try that. In the meantime, while you're working on pulling that up, I might ask one of the faculty a question. So, Mary, are you still there? Are you able to come back to the webinar? Perfect. Thank you so much. Again, excellent presentation, Mary. I think my question to you would be about quads. You mentioned that that's really taking off a lot now, and certainly that's what I'm seeing too. But in our adult patients, one of the concerns with quads, even though we're seeing good overall results, is the rate of Cyclops syndrome. And my concern is that maybe we see a similarly increased rate in our pediatric population too, and whether you take any steps to try and minimize that risk. Do you use a smaller graft size, or are there any other considerations?
Yeah, that's an excellent question, and I think definitely an important consideration. There is certainly a risk of osteofibrosis or Cyclops lesion in particular with quad autograft. And John Zaraginis out of Emory has done some great work with this. So I think the size of the graft is very important, and certainly in our pediatric patients, we need to be using a smaller graft because it's a lot of collagen and occupies a lot of space. And by having a smaller graft, that definitely decreases the risk of developing a Cyclops lesion. I know it's a risk. I haven't seen it in a ton of my own patients. I've had to go back once in the past maybe 6 or 7 years for a Cyclops lesion, but it is a very important consideration, important to keep in mind. And definitely in our pediatric patients who have much smaller knees, we need to be considering using a definitely smaller graft.
Thanks, Mary. Alessandro, it looks like your presentation is up, so please go ahead.
Thank you. I have nothing to disclose. So once considered rare, the management of pediatric and adolescent ACL injuries has gained significant attention due to increasing incidence. This increase is primarily attributed to more intense sports participation, early specialization, and continuous training through the year. In the last decades, there has been a paradigm shift from conservative management to operative treatment, reflected in a significant increase in pediatric ACL reconstruction worldwide. The main concerns with an operative approach are the risk of growth disturbances and the very high rates of ACL graft rupture, up to 32% in long-term follow-up studies. Consequently, there is room for improvement in the clinical outcomes of ACL reconstruction in pediatric and adolescent patients. In adults at high risk for graft rupture, lateral extraarticular procedures, either lateral extraarticular tenodesis or anterolateral ligament reconstruction, has been shown to be effective in significantly reducing the risk of ACL graft rupture in several comparative clinical trials and meta-analyses. So, given their function in controlling anterolateral rotatory instability and to reduce ACL graft rupture, there has been an increased focus on lateral extraarticular procedures in the recent years. There are a number of factors that motivate the addition of these procedures to ACL reconstruction. First, the peripheral structures have a longer and more efficient lever arm than the central structures, making them more effective in controlling rotation. Second, they have a protective function on the intra-articular graft. This effect was demonstrated in several in vitro studies, including those conducted by Engelbrechtsen and colleagues, by Draganic, and more recently by Marom and al., showing a significant reduction in load to ACL graft when a lateral extraarticular tenodesis was performed. And this load sharing has a protective effect, with particular emphasis on the initial postoperative period of integration and remodeling of the reconstructed ACL. The addition of a lateral extraarticular procedures results in better ACL graft healing and integration as assessed at MRI in both adult and pediatric patients. The third factor is that lateral extraarticular procedures are also intended to treat tiers of secondary restraints whose injuries result in increased rotational instability and pivot shift. In skeletally immature patients, there are several options for performing a lateral extraarticular tenodesis, depending on the physical status. In pre-adolescent patients, tenodesis can be performed without creating bone tunnels. And on the left, we can see a hamstring-based over-the-top technique fixed to the femoral and tibial epiphysis with suture anchors. In the middle is the well-known Cocker-Micheli technique, using a strip of fascia lata with an over-the-top configuration. But both techniques combine intra-articular reconstruction with lateral extraarticular tenodesis using a continuous graft. And in contrast, the technique on the right is the Arnold Cocker technique, a tenodesis with a separate graft, without bone tunnels, and with periosteal fixation. Other techniques that can be used include the execution of bone tunnels, and among these, we can see on the left the modified Lemaire, in which a strip of fascia lata is harvested and passed under the lateral collateral ligament and then fixed to the femoral epiphysis. In the middle, a hamstring-based over-the-top technique with bone tunnel in tibial epiphysis and metallic fixation, while an anatomic double bundle ALL reconstruction with gracilis tendon is shown on the right. In 2022, a survey was published on trends in adding a lateral extraarticular procedure to ACL reconstruction in children and adolescents. The study respondents were 87 surgeons within the Pediatric Research in Sports Medicine Society. And the survey revealed that surgeons primarily practicing sports medicine were significantly more likely to consider anterolateral procedure in conjunction with primary or revision ACL reconstruction. Common indication to add the lateral extraarticular procedure were high-grade pivot shift, knee hyperextension, generalized joint laxity, and type of sport participation. The modified Lemaire was the preferred technique for lateral extraarticular tenodesis, largely due to their familiarity and confidence with this technique, and significant barriers to the adoption of lateral extraarticular procedures included concerns about the lack of significant evidence and the potential over-constraint of the knee. In the same year, we conducted a systematic review that included studies that used different types of lateral extraarticular tenodesis to treat pediatric and adolescent patients. This review included 5 studies using different techniques, including a large series of 240 patients by Cocker and colleagues. And even on only a few papers, but the review showed that different tenodesis technique yielded to optimal results in terms of outcome, rearruptures, and complication. However, all the studies were case serious, and consequently, there were some methodological issues. Since then, subsequent studies with improved methodology have addressed the issue more comprehensively. For example, the study from the Santé Clinique of Lyon published results obtained with 2 different techniques of lateral extraarticular procedure, anatomic ALL reconstruction and lateral extraarticular procedure as modified Lemaire. They analyzed the result of 40 skeletally immature patients, and the mean age at surgery was 13.8 years. They reported that 92% of patients returned to sports with 1 graft failure, so 2.6%, and 5.5% of cases experiencing femoral overgrowth. The HSS Pediatric Orthopedic Group published an encouraging result on using of quad tendon for ACL reconstruction combined with the Lemaire in skeletal immature patients. Despite a relatively high number of reintervention, no patient had graft rupture, and all patients returned to sports at 2 years follow-up. And they recently just published the study, the same group, reporting clinical result of pediatric patient receiving ACL reconstruction with quad tendon, and they included patient receiving all epiphyseal or full transphyseal ACL reconstruction. And a significant number of patients also underwent concomitant modified Lemaire. The authors found that 24% of patients had subsequent reoperation for meniscal procedures, septic arthritis, lysis of adhesions, or limb length discrepancies, but no significant difference in reoperation rate were found between patients who underwent concomitant lateral arterial tenodesis or patients with isolated ACL reconstruction. Perelli and co-authors from Barcelona conducted a comparative study on adolescent patients receiving isolated ACL reconstruction or combined with modified Lemaire. The authors found that combined procedures lowered the failure rate and improved stability without increasing complication. And back in 2022, we published, I think, the first comparative study specifically in skeletal immature patients who received isolated ACL reconstruction or combined with an old soft tissue lateral arterial tenodesis, the Arnold Coker. The patients were selected for lateral arterial tenodesis based on specific risk factor like high-grade pivot shift, high activity levels, or participation on pivoting sports, or second fracture. We found that the addition of a lateral arterial tenodesis to an intra-articular ACL reconstruction with hamstring tendon significantly reduced graft rupture rates and improved knee stability when compared to isolated ACL reconstruction. And while graft rupture rate and knee stability showed significant improvements, PROMs did not differ significantly between groups, but we found that there were no differences in the rate of non-graft rupture related reoperation or complication between the patients receiving isolated ACL reconstruction or combined procedures. So in conclusion, currently the role of lateral exarterial procedures is critical in the care of skeletally immature patients with ACL deficient knees. And the addition of a lateral exarterial procedure to ACL reconstruction are demonstrated significant advantages over isolated ACL reconstruction in this population. So lateral exarterial procedures are safe and associated with a low failure rate, improved knee stability, and no increase in the rate of non-graft rupture related reoperation or complication. But however, few studies have addressed this issue, and further studies are needed to provide higher quality evidence.
Thanks, Alessandro. Excellent presentation. I'd like to invite all the faculty to come back into the webinar, and I'm going to hand over to Eduardo, who's going to take the lead on managing the questions.
Thank you, Adnan, and congratulations. Thank you to all the speakers. Very good presentation, clear indications. There are some questions for Nick, for example. Two interesting questions about the possible impingement, anterior impingement, when using the physical sparing technique, which is not anatomical on the tibial side. And another for you is, what's your preferred implant for graft fixation on the tibial side with your physical sparing technique?
Great points. For the tibial side, this is very, very real. You need to create a good groove on the anterior aspect of the tibia. And I demonstrated that you actually need to create a little bit of a groove on the bone, and you need to make sure, and it's probably one of the hardest things in the technique, to place your like retractor and to be able to have your Kelly clamp or whatever clamp you use under the intrameniscal ligament to be able to get that graft really sitting in the front of the groove. And then as you tighten it up, you need to make sure that you have your camera in, make sure that you fix it and it stays in that position. And for the tibial side, depends on the technique. For the IT band, I suture on the periosteum, so I create a groove on the periosteum, I open it up, and then I suture it with the graft incorporated and I bury the graft under the periosteum. For the all epiphyseal technique, I use a special fixation. I use, like the blind tunnel. I put my graft and then I put the, like a button, a tightrope, and I like cinch it in with an adjustable loop, so it would be easier to take the graft down from the interarticular portion and bear it on the tibia.
Okay, thank you. Another very interesting question is for Mary, but maybe for all the speaker, is a specific protocol. Is there a specific protocol for return to play in this particular kind of patients? And if there is for you a precise timing for return to sports? Mary.
Yeah, that is a fantastic question. And I think there's a huge amount of debate. We definitely don't have a standardization in terms of criteria that we use in kids or adults for that matter. In general, though, I tell my patients, that they won't get back to those, cutting, pivoting type sports for 9 to 12 months. They progress through rehab. Obviously, PT is absolutely critical, going 2-3 times a week for several months. I'd love for them to do physical therapy up until the time they go back to sports. I like to have patients, if they're able to do some type of objective testing, probably around 5 months for the first evaluation, and then maybe, at 8 months. So they have a comparison, because as we've all seen with our patients, functionally, they are doing very well. Usually like pretty early on, even after a couple of months, they are starting to feel good. 3-4 months, 5 months, they're feeling very good. But the objective testing with our actual data, whether you're doing biodex testing or Vail Sport Cord or any of those objective measures, that then helps us, the patients, their parents, coaches, understand that there is still a deficiency in strength and that there's still some work to do. So I think that it's the combination of the clinical evaluation, the progression with physical therapy, the objective measures that help us determine how our patients are progressing. And I think it's very important to have the conversation with patients from the beginning and their parents and everyone involved, that it's not just a time, a time situation. It's not at X amount of time that they're going to be doing this, at X at 9 months or at 7 months, they're going to be absolutely back to sports. It's all about how they're progressing through the rehab, and that they do have to meet those goals, and that they're doing these things too under a setting of fatigue, right? Certainly as they get further along in their rehab process, that they're doing it under a setting of fatigue, because that's what they're going to encounter when they're back on the court or back on the field. So important to keep those in mind. But the short answer is there's no set criteria. I do think it's important to include objective measures, though, so that we have actual numbers to show them strength deficiency between the affected leg and the contralateral lower extremity.
Thank you. Do you all agree with this timing, 9 to 12 months for these patients, or there is someone of you who is not in agreement with this timing?
I go a little bit early when they demonstrate that they can do it, and I trust them. And as I said, Mary made a very, very important point. When I have them do physical therapy for the full 6 months, and I know their sequel and advancement, when they demonstrate the functional tests and the strength tests that they are recovery is there, I bend the rules a little bit. I send them out six months.
Okay, so you don't think that we need to wait at least 9 months? Okay, maybe we have time for the last question, which is interesting for Matthew. Is there for you a best autograft option, and is this an optimal size of the graft when you use autograft for ACL reconstruction in pediatric patients?
I think if there was truly a best autograft option, we wouldn't have as many conversations as we do in these webinars and on these courses. I think that there's a role for all these grafts. Honestly, I have also gravitated towards quad tendon grafts as my soft tissue option. Like I think a lot of the literature and a lot of these conversations, because I like it being a single nice chunk of tissue. It's a lot of collagen. It's reproducible. I don't love the idea of harvesting hamstrings and hoping my size is going to hit what I want. But again, I think there's a role for all these. I think it depends on the sport, depends on, there's a downside to every single thing that we do, every graft option, every incision, all these techniques. Even, we talk about the fascial sparing extra articular techniques, and I've seen sometimes that lateral incision act up for patients. So regardless of what we do, there's a downside. So I think you just got to have that conversation with patients.
Is there for you an optimal size or minimum size of the graft?
No, because I think if the patient is tiny, then putting a 9 millimeter graft in there, it might look ginormous. So I don't think that there is. I don't think that the adult literature quite translates down. I think, Dr. Mulcahy made a great point about the size of the quad tendon. When you're taking that, if you're using a double blade or whatever you're doing, that's gonna be a big piece of tissue, and that's gonna be a small notch. So I think you just got to be mindful. I don't think there's an optimal, at least in my opinion. I don't think that the literature has necessarily guided us. I think you just got to take the patient's size into consideration.
Okay, thank you. Maybe we are in time, Adnan. What do you think?
I think we have time for a few more questions, probably. We still have quite a lot of participants signed on.
Okay.
So, Alessandra, I'll ask a question to you about lateral extra-articular procedures. You mentioned a whole bunch of different techniques there. Obviously, anterolateral ligament reconstruction is one of the most popular in the adult population, so is modified Lemaire. I know you published on the Arnold Coker modification. So that's a technique that perhaps people are less familiar with. Can you speak to the advantages of that technique? Is that your preferred one? And perhaps why should people pay more attention to that one? And what are some of the pitfalls of the other more common extra-articular procedures that are more frequently published on in the adult population?
Thank you for the question. The Arnold Coker technique is my preferred method in the patients in which I do ACL reconstruction with bone tunnels. So when I use bone tunnels for the ACL reconstruction, I have the fascia lata to do lateral extraarticular procedure. And then with Arnold Coker, we can do a lateral extraarticular tenodesis without bone tunnels or without bony fixation. And so we are not at risk to induce tenoepiphysiodesis. It's a very fast technique, easy technique, and it's all soft tissue. And so it's my preferred method. But the pitfall is that in very skinny guys, in very skinny patients, there is a little cosmetic issue because we pass the strip of fascia lata under the lateral collateral ligament and then back to jaundice tubercle. So there is huge depth in between the fascia lata, lateral collateral ligament, and then fascia lata again. So, and then scar tissue. So we can have some aesthetic issue with this.
I really like the technique because I think in the pediatric population, you're avoiding any additional bone tunnels. So there's no issues with real estate tunnel collision. And obviously there's no risk of injury to the physis from having to fix that graft. It's all soft tissue fixation. Thanks again for your presentation. Other questions that we have here are about rehabilitation, but one good one here is about non-operative treatment before opting for surgery. So let's have a poll of the faculty. Now that we've kind of trended away from non-operative treatment, is every pediatric patient getting an ACL reconstruction, or are some of you trialing a period of non-operative treatment first? How do you make that decision? So we'll go in order of the presenters. So Matt, your presentation was first, so maybe you could give your perspective on the role of non-operative treatment in pediatric ACL injuries.
I would say for complete ACL rupture with objective instability on my examination, there's minimal role, at least in my perspective right now, for non-operative management, given what we know about secondary chondral meniscal injuries. There's some interest, obviously, in the adult literature of maybe different bracing protocols and possible options here, but I want to let that play out in the adult literature for me personally before I, maybe bring that risk to the younger patients who have a lot of runway on these legs. Now, I will say the only, in my perspective, a partial ACL injury where they don't have quite as frank instability and examination, I think there might be a role there for non-operative management, getting them to therapy, get their quad strong, and see if they are continuing to subjectively have instability. That's got a role in my practice, but for complete ACL rupture with instability in my exam, I'm going to have a talk about of reconstructing it for the reasons that we covered in the webinar.
I agree with you, and I probably won't poll the whole faculty because I saw a lot of nods there, and unless anyone has a different opinion on that.
No, I think that this is what I do also as well for some of the partial tears, some of the sprains. What is important sometimes for these patients as well is to get a follow-up MRI and see how the ACL evolves over time, because sometimes you would have a partial tear that would evolve into a complete tear, and you won't be having the symptoms in the patient. Your exam may change as well, so follow up if there is a kind of a sprain is advised, or at least in my practice. But for complete, absolutely surgical management.
Another question we have in the Q&A is about allografts. So Saeed is asking if there's a role for allografts in those near skeletal maturity, and is there any age demarcation for using allografts or not? In my opinion, there's really no good justification for using an allograft in any pediatric patients. We know that the risk of failure is higher, and so autograft is the way to go, in my opinion. Does anyone on the faculty disagree with that? Okay.
No, I mean, I agree completely. And I touched briefly on this in my talk too, but I think important for all of us to remember that even augmenting an autograft with an allograft is still a higher risk of failure. So I think we, in the past, have thought about, oh, if you have a small hamstring autograft, for example, then augmenting it with allograft is better because it will, obviously makes it a little bit bigger, but still the risk of failure is much higher than when you're using the appropriately sized autograft. So no, I don't think there's an indication for allograft in our pediatric patients.
Absolutely. Nick, we have another question for you. And this is one where I'm excited to hear your tips as well. So basically, what tips and tricks do you have for avoiding the growth plate when you're drilling your tibial or epiphyseal tunnel?
So for the tibia, the trick is that you need to make the setting so your fluoroscopy will be able to take an AP and a true lateral. And what I find challenging sometimes is to get that true lateral. So I have a little bit more on the femoral side. So I set it on the side, and then I rotate the knee in order to be able to have that. So I set it so it would be oblique. And then I rotate the knee so I can have an AP. And then I rotate it to have a true lateral. And then my guide should be very, very close to the epiphysis. And I cheat a little bit in the center so you can take advantage of your growth plate in the front of the knee. That's how you can get the extra space for an adequate size tunnel.
Anyone else have any tips they want to share on that aspect? All right. We also have a question about the role of internal bracing. Are any of the faculty routinely using internal bracing in their pediatric ACL reconstructions? And if so, what's your justification for that? Doesn't seem like anyone's using that. All right, perfect. I think we're coming up to the end of time. That was a really fantastic session. I'd like to thank Eduardo for being an amazing co-host, and all the faculty for sharing their amazing expertise and their time to make this a really fantastic webinar. Thanks, everyone. I believe that ISAKOS will be sending out a survey at the end of the webinar, so please provide your feedback. Thanks, everyone. Have a great day.
Thank you. Thank you, Adnan. Bye-bye. Thank you to everybody.